Hi, good evening and welcome to this trauma care webinar. My name is Andrew Ormerod and I'll be facilitating the webinar this evening, and I will shortly be handing you over to Dr. Nick, talking pre-hospital blood, past, present and future. So I can already see that we are loading up with participants, and I can already see that somebody's beat me to the chat. So it's always good if you pop in the chats where you're dialing in from tonight, and maybe what you do for a living, and also maybe what interests you around blood. And if anybody uses Dracula or vampire, then you'll be kicked out at the earliest I get to have a look at you. So webinar disclaimer, any learning that has taken place tonight should not be solely relied upon to inform practice or indeed allow any practice outside qualifications. So anything that Dr. Nick tells you tonight, please take it as educational and learning content, but it's not a license to practice anything outside of this learning zone. Webinar rules and facts. Myself and Dr. Nick cannot see or hear you. So if you're sat there in your terry toweling dressing gown, or you've just got out of the bath and you're still drying yourself off, please don't worry, because we can't see you, and equally we can't hear you. So you don't need to fumble around looking for the mute button or to turn your video off. For members of Trauma Care, you will of course get a CPD certificate, and that will be issued tomorrow at around 10 o'clock. So once Lauren has come into the office, had her cup of coffee and her chocolate biscuit, she will issue you that CPD certificate, and that will come to your email address. And of course, as always, you will get a copy of the recording all nicely tidied up for you tomorrow with a start, a middle and an end, and that will come to you again by email. There might be some opportunities tonight to scan QR codes, certainly after the presentation. So if you are savvy out there with your tech, you can scan the QR codes. So you literally just point your camera or your iPad or your tablet at the screen and take part in some of that fabulous interactivity. If you are on Twitter, then please do follow us. That probably should say Trauma Care 2022, but it's okay. It means I will now hide the biscuits following this presentation, and they won't be available in the office tomorrow. But please do follow us at Trauma Care UK. It's always good to show us what you're up to tonight. So show us where you're learning, whether you're at work, whether you're in an emergency department, whether you're sat in a response car, whether you're part of a falls team. Please do take a snap of what you're up to and share it with us on Twitter, and I will guarantee you that I'll give you a little like and a little retweet while the presentations are happening. If you haven't bought your tickets already, the Trauma Care Conference 2022 live face-to-face conference is now available to buy your tickets. So we've got programs through from Sunday right through to Thursday, and of course myself and all the Trauma Care team will be at that conference. So it'll be a great place to do some networking and also some great quality education, as well as a great quality social experience, because of course you can stay over and there's everything there, including some amazing food and some nightlife too. So please do scan that QR code or go to the Trauma Care website where you can purchase your tickets for that event. If you're not a member of Trauma Care, then why not? Because there's lots of great benefits. In fact, I'm going to let you into a little secret, and you must not tell anybody, but today we have just decided some complete new benefits to membership, including a reduction in price and an increase in benefits. So I'm not going to let you into too much, but do follow us on social media, because I will tell you. Actually, I'm going to tell you. Can I tell you? Yeah, I will tell you. No, I can't. Yeah, I can. So student members, at the moment, only full members get a copy of the journal and the electronic journal. But very shortly, and you've heard this from me, and I'm probably going to get well done because I've got a good feeling that Professor Sir Keith might be on this webinar, but student members shortly will get access to the electronic journal. But you didn't hear it from me, but you did, if that makes sense. So membership, go across to the Trauma Care website. You can join £5 a month currently for student membership and £8 a month for full membership, but that may change very shortly. Watch this space. And of course, if you are a CPD champion within your workplace, all of our CPD webinars are completely free to attend. So please do download our poster and share our great, amazing webinars with your colleagues at work. You can pop a poster up on your work notice board. Strangest place I've ever seen one is in toilets, but there is stranger places. But if you can share it electronically, of course, then please do that, and it stops us having to print unnecessary posters that need replacing. All that leaves me to do now is hand over to Dr. Nick. So I'm going to stop sharing my screen and hand you over. Are you there, Dr. Nick?
Hi, good evening. I am going to share my screen And hopefully, there we go. Brilliant. Well, thank you so much for the introduction, and welcome to Trauma Care. It's an organisation I've been involved with for several years now, and some of the work that the Trauma Care do is phenomenal. The education that's provided is just amazing. Whatever area of medicine, paramedicine, fire, police that you're into, Trauma Care has helped so many people. And I'm delighted to have been invited this evening to talk about pre-hospital blood products, past, present and future. I think this was a canny piece of timing on Trauma Care's part, because I am one of the chief investigators for the RePHILL trial. And for those of you who are familiar with it, we published 2 weeks ago in the Lancet. For those of you that aren't, I will explain a little bit about the trial and what it means for pre-hospital transfusion across civilian practice, certainly, for the coming years. So a couple of disclaimers. I'm an anaesthetist by trade. I've got a 10-year background in pre-hospital care, PHEMS basics, previously training program director for PHEM in the West Midlands. And I am not averse to blood products. Everyone thinks that I am a champion of saline. I do use it occasionally in theatre, but I'm not averse to blood products. I have a very balanced view, which is where the RePHILL trial came from. I do name check a couple of organisations and air ambulances in this presentation. My view is, if you put something on social media, you are eligible to be quizzed about it. So I make no apologies for that, and I would fully expect someone to do the same back to me. So where did all of this start? Pre-hospital blood products have been around for years, and I did notice that there was a presentation not so long ago by Jason Smith, and he went through a lot of the history of the old history of transfusion. So I won't repeat that again, because if you saw Jason Smith's excellent presentation just a few months ago, that will be old news to you. So I'm going to talk more about what's happened in the last decade and the next decade. So pre-hospital blood products for us became a thing on the battlefields of Afghanistan. And that was back in 2000 2007, 2008, when there were the British Medical Emergency Response Teams, the MERT, plus the American Pedro and Dustoff teams, and they were all fulfilling the same function. But the British MERT was going out to soldiers who'd been horrifically injured through improvised explosive devices, gunshots, blast injuries, and repatriating them to the forward hospital in Afghanistan, Camp Bastion, before repatriation, then back to Birmingham, which is where I was fortunate enough to look after and meet these soldiers. The military started carrying packed red cells and plasma, and did a bit of a retrospective, prospective look, and they found out that the more patients were getting back to Camp Bastion and surviving after the introduction of red cells and plasma. So we instantly had some evidence that pre-hospital blood products conferred a survival benefit, which was amazing. Those patients, don't forget, are a very narrow demographic: young, fit, predominantly male, predominantly without any other medical histories, suffering catastrophic injuries, some non-compressible, hemorrhage, some blast injuries, and they were a long way from medical support. They had to wait for, other than the immediate tourniquets, they had to wait for the MERT team to retrieve them, and then a long transfer back to Camp Bastion. So you've got a very unique set of circumstances. But because the military are doing it, and it's kind of cool, it translated across to civilian practice. And this is a BBC report from 2012. London Air Ambulance started carrying blood products in UK civilian practice, the first such service to do so. They name-checked the British and American military for the credo, the coal boxes that were being used. The bottom line is where all of this started for me. And they believed hundreds of lives could be saved and regional services were looking to follow suit. So I was at that time the medical lead for Midlands Air Ambulance, based in the West Midlands. And I'm also a resuscitationist. I'm a trauma anaesthetist, and I wasn't quite so sure. But the snowball started to roll. Other services took up. This was 2016. Same BBC. Great North Air Ambulance Blood Service have saved lives. 18 lives have been saved. And again, another great press report. You've got cameramen on the helipad, and it's really good PR. Great Western Air Ambulance, so down in the southwest, they started providing pre-hospital blood products, and they have no doubt that lives have been saved, and they were then going to try and prove this statistically. And that was where we got to. There was a lot of excitement, there was a lot of press releases, and it became fairly common practice. And whilst the enthusiasm for blood products was increasing, there was a bit of a look as to how we were getting on. Very early in the London Air Ambulance experience, the London Air Ambulance team and Weaver and co did present a very, very initial early first look. What happened, and the conclusion at that time was the introduction of on-scene transfusion improved the ROSC rate from traumatic cardiac arrest, but didn't result in a survival benefit. So they were getting some resus, but those patients were still dying. So that was very early days. I mean, bear in mind, 2012, 10 years ago, the trauma networks that we're so used to now had only gone live in 2012. Damage control surgery, we were only learning from Afghanistan at that time. So there was an awful lot to move on. If you move on 6 years, we've now got established trauma networks, damage control resuscitation, damage control surgery, and all of the other innovations that have happened. You would expect things to have moved on. And in 2018, the same team, and Weaver, Dave Lockie, published in Shock the effect of pre-hospital red blood cell on the mortality and time of death. And the conclusion was that pre-hospital red cell transfusion was associated with increased survival to hospital, but not overall survival. And all that we were doing at the time was delaying death. So the military experience wasn't being translated into civilian experience. And the thoughts were, well, we've just got to work harder. We probably need to give more people blood. And this is where the problem is. And for those of you who are transfusionists, work in blood banks, this may be a little bit simplistic, and I apologize, but it's really important, if we're going to talk about pre-hospital transfusion, to be absolutely crystal clear what we're talking about. This is not blood. These are packed red cells in an additive solution, and these are what are being given. This is blood. This is my blood. And I'll be absolutely clear that if I was to walk out of that village hall, get back on my motorbike and get hit by a truck and was bleeding to death, you quite happily go in, get that bag, put it back in me, because that is complete, true whole blood. More of that later. But what we were talking about previously are packed red cells. Now, whilst the enthusiasm for transfusion was growing, the alternative, what most of us that have ever set foot on the back of a standard yellow ambulance use, is normal saline. And normal saline's had a really bad run for this. It's called pasta water. It's called Satan's fluid. It's called poison. And I think, firstly, that's really, really unhelpful. I was in theatre today at the QE. I was giving crystalloid to patients. Everybody gets crystalloid. You walk through wards, you walk through A&E. And to say that we are poisoning our patients every day in every hospital up and down the country, I think is downright dangerous. And calling it pasta water, I don't think necessarily is giving you the whole answer. And bear in mind this Satan poison that's talked about. is sodium chloride. It's got a bit of sodium in it. It's got a bit of chloride in it. Red cells, blood, is a completely different thing. And it's actually a very, very weird solute with some red cells added. And I would argue that if I got you out a bag of this in hospital and said, I want you to give that as a resuscitation fluid, you'd probably say, why isn't that in a locked cupboard? Why don't you have to sign it out of some register? Look at that potassium. Look at the glucose. We know that hyperglycemia damages people in trauma. We know that lactic acid and lactate is a marker of illness, and yet we're feeding it to people. And yet if you get a bag of red cells, I'm not suggesting you do this because your hospital will go nuts, but put a bag of red cells through a blood gas analyzer, that is pretty much what you'll see. And for me, that is a really, really strange choice of a resuscitation fluid. It's certainly no more dangerous than pasta water, no less dangerous than pasta water. And yet this is seen as the gold standard, and saline is seen as less of an alternative. And this is what bugged me, and this is why I wasn't sure that red cells were a brilliant resuscitation fluid. Great cure for anemia if you give it slowly and allow the body to deal with all of that, but not a great rapid resuscitation fluid. And that was where the RePHILL trial came from. With that in mind, I looked, well, we, my team, my colleagues and I did a systematic review and looked at the evidence for pre-hospital transfusion. And I won't bore you with our systematic review, but there was very, very little. I think there were 27 published papers, of which only 12 were civilian, of which those 11 were retrospective. So there was only one prospective study, and that was still not randomized. So there was no good evidence about resuscitation fluids and blood products. And yet it has become a real thing. People are staking their reputations on it. Air ambulance charities are using it for press releases to raise money from the public so they can support the service. NHSBT are providing these blood products to patients, and yet there is no evidence. And I felt very uncomfortable signing up to join that bandwagon without the evidence. So we put together RePHILL. And what RePHILL set out to do was look at pre-hospital blood products, plasma and red blood cells versus saline, standard care. Was there an improvement in the quality of resuscitation? Was there an improvement in mortality? And we set out to capture 480 patients, enroll them into one or the other arm, randomization, and follow them up like no trauma patient has ever been followed up before. It's about as difficult a trial as you can possibly do. It's a pre-hospital, multi-center, randomized controlled trial. You've got no control over where the patients go. The blood that is issued from one hospital might end up at another. The patients can't consent because of the nature of their injuries. It's 24-hour-a-day, 7-day-a-week recruitment, using red cells and a freeze-dried plasma called Lioplas, and we then ran it. It was approved by the ethics and the MHRA and funded and went live. We had a lot of collaborators. We had 4 amazing air ambulance teams, the Derbyshire, Leicestershire, Rutland, Warwickshire, Northamptonshire air ambulances, Midlands Air Ambulance, Magpas and East Anglia. We were also supported by West Midlands Ambulance Service, NHSBT, University of Birmingham with the clinical trials unit. We had some staff support from Warwick University, and University Hospitals Birmingham, the QE, was the sponsor of the trial. And obviously the National Association for Blood Banks, who I cannot thank enough, who rose to the challenge and started getting all of these blood products to these random airfields all over the country without any hassle at all. The blood bikers were amazing, and they are the absolute unsung heroes of this. So that was who was involved. How did it work? The local blood bank to the air ambulance team would be allocated whether there was blood products or saline. Identical credo boxes were then loaded with either 2 red cells and 2 plasma, or 4 bags of saline, and then taken to the air ambulance base. The boxes were identical in weight. If you shook them, there was no way of knowing what was in the box. And the air ambulance teams would then go out to a patient who they would then assess for eligibility. The inclusion criteria were that they had to be hypotensive because of believed hemorrhage, and the PHEM team had to be able to treat them. Obviously, we excluded patients that refused blood products, so Jehovah's Witnesses or any other refusal of blood. Children, pregnancy, prisoners because of difficulties with Ministry of Justice and consenting, and isolated head injuries who we know exhibit strange blood pressures and heart rates, but not due to bleeding. And we then collected the data. The trial ran. We fell slightly short. We got 93% of our target numbers because of COVID and all research being paused. But you will see that even though we fell short, that does not affect the results, because the message from RePHILL was so clear that we looked at every eventuality, whether the remaining patients all benefited, all came to harm, or everything in between, and the results wouldn't have changed. So I'm pleased to say that RePHILL results are nonetheless valid. How did we do? Well, the important thing in any randomized trial is that the 2 populations you study are the same. So in the packed red cell lyoplasm, I'll call the blood group, 82% male, 18% female, as is very common in trauma. And in the saline arm, 82% male, 18% female. Looking at age, the average median age in the blood group was 38, and in the saline group was 39. So we've got the same people enrolled in both sides of the trial. In terms of the mechanism of injury, again, very reflective of UK civilian practice: 78% blunt, 23% penetrating, and 3% crush. And before you spot that they don't all add up to 100, you could be in more than one group. In the saline arm, 80%, 22%, and 1%. So again, similar mechanism of injury. Patients in cardiac arrest, 14% in one group, 11% in the saline. So broadly similar demographics of injury. One of the first things that we wanted to study was, does the administration of blood products count as stay in a play and saline count as scoop and run? Were we spending more time on scene with patients receiving blood products? And the median time to get the crews onto scene was 26 minutes and 27 minutes in the saline arm. The time to intervention, which is what I was discussing, the time to actually deliver the products, so from arriving on scene to treating, was 22 minutes in the blood group and 21 minutes in the saline group. So actually the administration of red cells and plasma, RePHILL can say definitely doesn't delay scene times and doesn't delay time to treatment. Were our patients injured was the next question. Were we actually getting patients that needed blood products? Did we pick the right patients from our inclusion criteria? And you'll see that the average heart rate in our blood group was 112, so that's a high heart rate, and 109, 110 in the saline group. Our systolic blood pressure median was 70 in the red cells and 70 in the saline. So we've got a patient population matched in demographic, matched in mechanism of injury, who are hypotensive and tachycardic. when our teams get to them. So they sound very much like the kind of patients that we would be wanting to transfuse. So I've skipped an awful lot of other demographics because the important thing and the reason that I've spent the last 8 years of my life living and breathing RePHILL was, do red cells and plasma make a difference? Our primary outcome measures were clearance of lactate, which is showing that the body is being perfused, your tissues are being perfused with oxygenated blood, so you're not generating lactate, and your liver is adequately perfused to clear the lactate, and death at any time during. So the patients who failed to clear their lactate or died, 64% in the red cell lyoplasm group, and in the saline group, 65%. So for those who, with a smashing of statistics, the risk ratio was 1.01, the adjusted risk difference was 0.25, 0.25%. So what that says is that there is no difference in mortality or quality of perfusion between those that received blood products and those that received saline. The confidence intervals are respectable. The confidence intervals being, what are the chances of this being wrong? But they completely straddle 0, and 0 is where there is 0 difference. So what RePHILL showed, much to a lot of people's surprise, is that packed red cells and lyoplasm did not confer the benefits that we were looking for. One of the other questions was looking at mortality and the 3-hour mortality. Bear in mind that London had shown that they got more patients to hospital. In the red cells and lyoplasm group, 16% 3-hour mortality, and in the saline group, 22% 3-hour mortality. Still very, very small differences statistically, but if you look at the adjusted risk difference, there's very, very little on one side of the naught and -15 on the other. So it did show that there was potentially a 7% reduction in mortality in the packed red cell and lyoplasm group, which supports what London Ambulance showed in those two papers. Number needed to treat, if that's your thing, is 15. The number needed to treat to prevent a 3-hour mortality is 15. Now that's quite a lot of patients who are being transfused. Certainly not the hundreds of lives being saved, but there is certainly an advantage. If we go further forward, and bear in mind that London Air Ambulance used the words delaying death, the 30-day mortality from all causes, 42% in the red cells lyoplasm and 45% in the saline. That gives an adjusted risk difference of 4%, but you can see from the confidence intervals, -13 to +6, that it really does straddle naught. So there is a chance, a 6% chance that actually saline is better. There's a 13% chance that red cells are better, but you can't say that one is better than the other because they both still cover naught. And the number needed to treat to save a life at 30 days was 27. Now, if we put that into context, average air ambulance may be giving 2 transfusions, 3 transfusions a week. So that in an air ambulance might be 1 or 2 lives saved a year by giving red cells and lyoplasm versus saline. Certainly not the hundreds of lives being saved. And there are certainly other interventions that are also equally, if not more effective, like keeping patients warm, early antibiotics, and so on. So number needed to treat at 27 is quite high for such a complex intervention. So why is this? Everyone who has taken to Twitter has been concerned about, well, the biological plausibility. Why aren't red cells showing that survival benefit? And I don't know if you remember a bit earlier, I said that red cells are a brilliant cure for anemia but not for hypovolemia. Those of us that work in hospitals know that we don't transfuse patients unless their hemoglobin drops to normally below 80 or 8, depending on how you do your hemoglobin. And that was what I was used to, certainly working in theatres and on the intensive care unit for the soldiers back from Afghanistan. We would deliberately run them with a hemoglobin of 8 to 9 because actually that conferred some benefits, good oxygen delivery, but reduced viscosity of blood. And if you look at the arrival hemoglobins in the 2 arms of the RePHILL trial, you can see that the patients receiving red blood cells had a slightly shifted hemoglobin curve to the ones receiving saline, as you'd expect. But if we then look at the transfusion trigger of 80, you see that only 6% of patients receiving just saline, not receiving any blood products at all, came into A&E with a hemoglobin that would, in hospital, trigger a transfusion. So the anemia caused by major trauma isn't being seen even in patients that are receiving 1 litre up to 2 litres of crystalloid pre-hospitally, apart from the very, very bottom 6%. Everybody the other side of the line wouldn't normally receive a transfusion if they were in hospital. So maybe we're actually not recognising which patients are needing blood products. Secondary outcomes, we looked at all sorts of other things in these patients, and we then did other analyses. So maybe it's the patients who are a long time from A&E. So we separated them into those that were less than an hour and those that were more than an hour. No difference. Is it blunt? Is it penetrating? Is it crush? No difference. Is it age? Is it whether it's compressible or non-compressible or both? No difference. What about patients that are on anticoagulation or antiplatelet therapy? No difference. The only statistical difference that RePHILL showed was that the patients that arrived having had blood products had a higher hemoglobin. That was the only statistically significant difference. Everything else showed that there was no difference. And just after the RePHILL publication, there was confusion. So having been sold and told for so long that saline is past the water, blood product is saving lives, it's making people better, people started to say, well, hang on, why is this happening? And I've talked an awful lot about red blood cells here. What about the other components? What about plasma? So plasma isn't quite as toxic as red cells in solution. Plasma has other benefits, obviously promotes clotting, it's a good volume resuscitation. Maybe just giving plasma would be the right answer. And as you may or may not know, there were a couple of studies done in the States in 2018. They published within a month of each other. This was the PAMPA trial, looking at pre-hospital plasma during air transport in trauma patients with hemorrhagic shock. And the PAMPA trial was spectacular, and it showed that there was a 10% reduction in mortality if you gave patients plasma over crystalloid. And everyone went, wow, okay, so plasma is the thing. Unfortunately, the next month in The Lancet, the Combat paper published, plasma resuscitation, treating hemorrhagic shock during ground transportation, and they were stopped after getting 144 out of the 150 patients because of futility. There was no difference at all. So you've actually got 2 very similar trials, one showing a benefit and one showing no benefit. So again, more confusion. So my brain's beginning to hurt at this point, I'm sure yours is. Can we summarize the evidence? So there's the proper study looking at 1:1:1 plasma to platelets to red cells versus 1:1:2 plasma platelets red cells. So more plasma or more red cells, and that showed very little difference between the 2 groups. PAMPA looking at plasma showed a benefit. Combat looking at plasma showed no benefit. RePHILL showing looking at packed red cells and Lioplas, no benefit. London Air Ambulance, with their earlier work, looking at just packed red cells, delay of death, but no overall benefit. So you can start to see why what sounds like a great idea and biological plausibility, give blood if you're bleeding, actually is a lot more complicated than as it was perhaps first thought. So what next? So forthcoming is going to be the SWIFT trial. This isn't my trial, but I am excited by it because it's sort of like the offspring of RePHILL. It's going to use an awful lot of the same methodology that RePHILL used, packing into boxes, unbeknownst to the crew, either whole blood or red cells and plasma. So the red cells and plasma is very much what RePHILL's done. The whole blood is not fresh blood out of your arm because it still needs to be processed. White cells need to be taken out, but it's red cells and plasma and platelets packaged into a single bag. We are still looking for that elusive resuscitation fluid that makes a difference. And what SWIFT are going to do is they're going to add platelets to the mix. We're still giving red cells, which personally I think it's debatable, but we're adding platelets and we're giving something far more akin to blood, certainly more so than red cells. And the SWIFT trial is in setup at the moment and will be launching soon. And I think most air ambulances, if not all air ambulances, are going to be participating. So you may well come across SWIFT either at the roadside or in the emergency department of your hospitals. So for now, what do we need to consider? What are our goals in resuscitation? Our goals are to get patients to hospital alive. So the delayed death, you could argue, is a valid goal because at least you're giving the patients the benefit of accessing hospitals and all of the infrastructure that there is there. But if they are already beyond helping and are going to die anyway, is that a goal? That's one for the ethicists to discuss. What are our goals in resuscitation? What are our endpoints we're looking at? Do we want patients to arrive normotensive with a normal hemoglobin in the emergency department, even though we've given them a huge metabolic insult from all the red cells and the lactate and the potassium and the glucose that go with it? Do we allow patients to arrive with a blood pressure of 90 systolic and maybe not use the red cell transfusion? Maybe, as RePHILL showed, even 500 mils of saline can be enough just to bump up your circulation, enough to get you to hospital without the metabolic carnage of the red cells. What are the endpoints? Who are we trying to do? And that brings you on to the patient population. Who should we be transfusing? Is it everybody? Are we all cavalier with transfusing patients at the side of the road? Or do we need to refine our patient population? I worry a little bit about transfusion. Blood stocks. Blood stocks are low. COVID certainly put us within a day or so of running out of O negative blood back in December. Amber Alert, talking about stopping operations. And we have to remember that the people that are involved in this are not just the patients that we treat. They're also the people who donate the blood. And if they know that their blood is going to a service where there is no perceived benefit, how does that affect donations? And would you be happy to go and give your blood now knowing that RePHILL has shown that there is no benefit to it? So what RePHILL hasn't looked at are the patients that do benefit. And I am absolutely clear that there is a role for pre-hospital blood and hospital blood products. But if we start to think about how that came about, the air ambulance charities promoted it. They were advised by their medical staff that this is the next best thing. They went and fundraised. We then took some established dogma that pasta water is bad and blood is good. We dressed it up in a sort of flight suit and everything that goes with that. I can say that I'm one of them, with very little evidence. Now, if we were to set up a system in the country of delivering something as precious as your blood that you've donated at the side of the road, is that how you would want it set up, based on media, press releases, PR firms, advertising, air ambulance charities to the local population, using non-evidence-based dogma driven by the desire to do the next Gucci best thing? And I would say that is not how I would personally set up a service. What I think we need to look at are who the patients are that will benefit. We know that it worked in the military, in that geographical environment with those huge injuries. We also know from RePHILL and the London Air Ambulance work that in urban and suburban UK civilian practice, we don't see those benefits. So are we too cavalier? Are we giving too much blood out? Do we need to refine our groups, maybe use it once every couple of times a month rather than a couple of times a week, on patients who are more likely to benefit from it? The patients who are trapped and we can't get them to hospital, who are bleeding. And the one example I often use is Leah, who was at the front of the Smiler ride at Alton Towers. We all remember Alton Towers. And she had injuries to her lower limbs, and she was trapped up in the sky on the front of the Smiler ride. And our Midlands Air Ambulance team brought blood to scene. This predated RePHILL, this predated blood on board, because she was trapped and she was bleeding and needed that care in situ. And without it, I dread to think what would have happened. But that is far more akin to what happens in the military experience and in the rural outback in Australia, where you have these long extraction times. So I think we need to just consider what we're doing, where the evidence is, not just be swayed by biological plausibility trumps everything, and actually start to look at how we, if we had a blank sheet of paper, how would we design a service? Because I think we do risk this snowball effect carrying us down a path, and it's very difficult to say, do you know what, this wasn't the right thing to do. RePHILL isn't the answer. It's one piece of the jigsaw. I'm really excited for SWIFT when it follows. And the work that Jason is doing, I think will be fascinating. I look forward to supporting it and helping it. And it will get us one step closer to defining how we best resuscitate the sickest of our patients when they need it the most. That's RePHILL. That's my view on where we need to go with pre-hospital transfusion. And I would be fascinated for any questions, any comments. RePHILL's still very new out there. It's only 2 weeks old. So I'm learning huge amounts from the feedback. So please don't hold back. If you think the trial's rubbish, tell me why, how we could have done it better, because there will be more trials that we'll learn from this. But for now, thank you so much for your time. I hope I've kept you roughly interested, and I will hand back to Trauma Care Office.
Dr. Nick, thank you so much indeed. So what I'm going to do is we've only got 1 or 2 questions just come through at the moment. So I'm just going to quickly whiz through the rest of my slides. Well, indeed, I'm going to let people pop their questions into the Q&A box. I have no doubt, Dr. Nick, there will be lots of questions. So I'm going to give them a couple of minutes to line them up for you. And then I'm going to let you have a look at the Q&A and we'll select the ones we're going to answer. You've probably already seen that I've got some, I think the trendy word for it, my daughter calls it merch, but I'm brandishing some of the fabulous new Trauma Care merch tonight. I had to Google search that to make sure it's a real term, and it really is. And so if you fancy some Trauma Care merch, or indeed some of our new Trauma Care manuals or books, then please do either scan that QR code or you can jump over to the Trauma Care shop, where we have just seen somebody's just bought a black t-shirt actually, so thank you so much indeed. If I knew how to pack that and put a packet of biscuits or some goodies in, I would do, and make sure it comes in the morning, but I've no doubt the team, when they come in tomorrow, will get that done for you quickly. Big thank you to our sponsors. We've got 3 sponsors. We've got Galon, who are the manufacturer of Penthrox, and again, there's some amazing resources there if you scan that QR code. So anybody who's doing any research into pre-hospital analgesia, please do have a look at their website. Or there's lots of academic learning and articles across on their site. We've also got Safeguard Medical, who's part of the Watergel Group, who's part of the Safeguard Medical. Gosh, that's hard work. So you can jump across and have a look at watergel.com, or you can go across and look at Safeguard Medical, who's got some amazing kit on there. I've recently seen one of their mannequins, and there's just some really amazing pieces of kit. And also our last sponsor is Icarus.com, and they are currently recruiting, so please have a look over at Icarus.com, or again, you can scan that QR code and have a look at their amazing website. They're doing all sorts of exciting and fascinating things at the moment all over the world. So let's have a look at Q&A. Let's have a look. We've got a question from David. David said, I'm just wondering about colloids. Were these considered in any trial?
Thanks, David. So no, I mean, colloids have, I mean, if we go back, I mean, what seemed like a good idea at the time, I mean, the trouble with crystalloid is obviously they're very transient in the circulation and disappear. Colloids, gelfusin, sort of artificial colloids and albumin were then thought to be a much better alternative. But very quickly, we discovered that the use of colloids in trauma was actually counterproductive and was potentially causing harm. So colloids have really fallen out of favour with trauma resuscitation. I personally don't remember the last time we used any colloids. The closest we get probably is plasma, and so plasma or albumin, but albumin's not great for this kind of rapid transfusion when you can give plasma. So we didn't consider colloids. What we wanted to do was say, what can we use? What's currently being used by ambulance services? Saline. And what's seen as being the gold standard at the moment, which was red cells and plasma. And that, so we took what was meant to be the best that money could buy, and what was standard practice across Europe, across the world for early resuscitation crystalloid, and that was the answer that we were looking for. That was the question we were asking. The other thing, and you've made me think about it, was that one of the other things that RePHILL showed, it depends how you spin it, not only are blood products no better in our population than crystalloid, but it's also really important for all of us that work on the frontline ambulance service. We don't have the luxury of PHEMs or Merit or anything else, and we are in ambulances going out to patients that saline is no worse than blood products and crystalloid. So what I was saying earlier about the people saying, "Oh, pass the water, Satan's fluid, it's poison," might actually make you get into your ambulance and look at the fluid that you've got and go, "Oh my gosh, I'm poisoning my patients with pasta water." That is not true, and you can give crystalloid, obviously in small boluses, to looking for a clinical, radial pulse or whatever, without worrying that you're harming the patient. And that's so RePHILL can give you confidence that whatever you're using, you're not going to cause harm. So I've kind of waffled on a bit when you asked about colloids, but the short answer is no, we didn't use colloids. We didn't consider colloids because we wanted to compare what was in an ambulance to what we were being told was going to save hundreds of lives. And that was where we considered.
Thanks indeed, Dr. Nick. Just spinning through the chat very quickly, we've got a selection of people from literally all over the place tonight. We've got Leslie Ann, who's from London Ambulance Service. Good evening. Good evening from Yeovil, Somerset. To Serena. We've also got Adrian. Good evening from Romania. Good evening, Adrian. Great to have you on board and join us. And we've also got a comment in there from, actually, it was another comment. Justin Davis has said, right, boss, that lad. I don't know if you know Justin, Dr. Nick, but he said you're a boss. I think that's yeah.
Sometimes I've got to be called a lad, I'll take that.
We've got Helen from Real Evening, Helen. And then we've got Christopher. I shared the paper with some people for Thor and had some feedback, if I may share them. Please do. You can either share them in the chat, Christopher, or if you want to, you can pop it in the Q&A. Or if you really want to, I'll happily open your microphone up and you can come on live. We've got a question from Tara. Hi, has it been considered using crystalloids and blood products together?
Crystalloid blood products. So what happened in RePHILL was we wanted to make it as real world as possible. And we know that the HEMS teams are often called to support ambulance crews, delayed tasking and so on. So if we had said that the only thing you could receive was blood products, we would never ever have got RePHILL off the ground. So all of the patients, or I say almost all of the patients, had received saline before the HEMS teams got there with the blood products or the saline. I think the average was somewhere around 500 mils of fluid early. So then, actually, no, sorry, 430, I think. So people were getting saline before they were enrolled, because actually we wanted RePHILL to reflect what happened in everyday practice. So they got some saline and then they were enrolled. If they had got some blood products, say another air ambulance had arrived first, they couldn't be enrolled in RePHILL. But we would allow them to receive saline before, and then if the box was opened and it was saline, we obviously got more saline. If the boxes were opened and it was blood products, and the patient was really big sick, red cells, plasma, and then you've run out and you need more fluids, you would then do what you would normally do, which is revert to more saline. So the patients did, on the whole, get a mix. What we were interested in is, in the real world, when patients have early treatment by first responder, first person on scene, then the enhanced medical team arrive and give their products. Did that make a difference? So it was sort of a hybrid, but that was designed to make RePHILL as real world as possible, as applicable as possible to the practice that we actually see every day out on the road. So I hope that sort of answers that it was crystalloids and blood products, but what we were trying to control was what the enhanced care teams, the HEMS teams, brought with them. Tara, if you want to just put another thing in question answer and let me know that I've answered that enough, that would be great.
Fabulous. Just quickly looking back in the chat, some really good comments there. Ian's put, thank you, Dr. Nick, very informative. Charlotte, brilliant talk, thank you. Shaz, Dr. Nick, nicely presented, thank you. Miss Shaz Hussain, Hannah, thank you. Great talk as usual. Kane, Daniel, thanks for tonight. Went nicely while drinking the whiskey. Fabulous, Daniel. You are so
Daniel,
lucky.
I'm with you. I'm with you in about 10 minutes.
And then Kane, great talk as usual. Difficult some of us ambulance clinicians have is our sodium chloride usually comes out of a cold response bag and have no access to fluid warmers. That puts me off more than the thoughts of pasta water. I'd put an IRF in, incident report form, Kane, especially if you work nights. I do recall in my good old-fashioned ambulance days, fluid warmers were most important for keeping fluid warm, but equally for also putting your kebab in there if you got a shout on your way back from the takeaway. So you need to put an incident report form in and get that fluid warmer fixed.
Kane, absolutely. And when you pick up a bag of saline and you're squeezing in and it's so cold that it's hurting your fingers, I know. I mean, it's the worst thing ever. And cold fluid, I am sure, probably does more damage than anything. And when I showed you the numbers needed to treat of 27 to save one potential life with blood products, and all of the costs and the logistics of getting the blood to and from blood banks in cold boxes, and all the education and the traceability and everything that goes with it, the enormous logistical, educational and financial cost of blood products, what I would suggest is, would that money be better spent on fluid warmers? Some mechanism of warming fluids that are going into patients every day up and down the country. So yeah, I think Kane actually bring up a really good point. And if we're talking about resources, is further investment in blood products based on what RePHILL has shown the right thing, or should we be actually investing in doing the simple stuff really well? Because the risk is we concentrate on the clever stuff and leave the really simple stuff, like just warm fluids, to one side. I personally am a huge believer in doing the simple stuff absolutely brilliantly, and I am convinced that you do more good than focusing on new techniques that are yet to be proven. So thank you for that, Kane.
Comment just coming there from Aldwin. Warm fluids are also good for external warming of patients, such as placing them under armpits and chests. And yeah, fluid warmers are a challenging thing. I've worked on lots of vehicles where they either work really well or they just don't work at all. And so, but you must put an incident report form in and report it. Don't presume somebody else has done it if it's not working. There is just one more question in the Q&A box, Dr. Nick. As a layman, I may have misunderstood this point, but before randomization, participants had received an average of 430 ml of crystalloid fluids and TXA acid 90%. Would that not have compromised the efficacy of the blood product when delivered?
Brilliant. I don't know if that question came in before or after I was answering Tara's question, but yeah. So we've got a patient in front of us who we believe is bleeding. We have got a patient who has got a blood pressure of 70 or less systolic, tachycardic, and you know that there's a HEM team on the way, but they're not there yet. So to give a little fluid bolus, 430 mils of crystalloid, that was the number, was essential. It wouldn't compromise the efficacy of the blood product because packed red cells are super concentrated. If your normal hemoglobin runs around sort of 14 or 114, depending on which number which kind of unit you use, I'm old-fashioned, 14. Packed red cells can't pack a bit of a punch, and they come in at about 18 or 19. So they're very, very thick and concentrated. And if you go try to squeeze it through a drip, it's really hard. So Christopher, basically the 430 crystalloid beforehand wouldn't reduce the efficacy of the blood product, but it would actually keep the patient going until the blood product got there. Tranexamic acid, 90%. That's based on another big study called the CRASH study, which looked at this very, very simple drug, which basically, long and short of it is, it stabilizes blood clots. So if you've got bleeding and it's started to clot, the tranexamic acid supports that clot and keeps it in place. So the TXA, tranexamic acid, was entirely beneficial based on the CRASH study. And the crystalloids that received before randomization was purely essential to keep the patient alive, but it wouldn't have affected the blood products. If I'm in theatre, we will use crystalloid for an operation until such time as the patient starts to need blood, and then we will give very small amounts of blood to bring the hemoglobin or their clotting back up again. So crystalloid and blood are often used together. One doesn't compromise the other, but to give the crystalloid was essential if we were actually going to get RePHILL as a real life study as opposed to just an academic exercise.
Thank you very much. Dr. Nick, that is absolutely perfectly timed, 20:59 and 15 seconds. So thank you so much indeed for such an engaged, it's just, well, there you go, 2,100 hours. The most perfectly timed webinar with Q&A you could ever not underwrite. So Dr. Nick, thank you so much indeed for joining us tonight at Trauma Care and for talking about such a fascinating subject and study.
Brilliant, thank you so much. And all I'd say is the RePHILL Twitter page has gone quite quiet now that the results are out, but there is a link to the Lancet paper on there. It's RePHILL_trial. And look out for the SWIFT trial coming your way. There is so much more to talk about with pre-hospital blood products. But for now, I'm hoping that we can just start to reflect on some of the practice and some of what we've been told previously, and look at how we steer things for the future. But thank you for the opportunity to present. It's really been great, and also seeing all the comments coming through. Really lovely. Thank you.
Fabulous. So don't forget, you will get your CPD certificates tomorrow if you remember, around 10 o'clock in the morning. If you haven't done so already, please jump over to the Trauma Care website. If you haven't got your tickets for the conference at the end of the year, please do so, because they are selling quickly. And we've got some great offers on there at the moment from 40 quid, which is cheap as chips, as they say up north. And also you can jog onto the website and register for next week's webinar. So we've got a couple of webinars coming up, road traffic related injuries. And we've also got Q&A session on chest injuries. So jump over to the website, get yourself registered. If you are at work, please stay safe. Thank you for doing an amazing job. If you are at home, kick off your slippers, enjoy the rest of your evening. Maybe pour yourself a glass of whiskey or a cup of tea, or maybe a glass of wine, however or whatever tickles your fancy. Dr. Nick, thank you so much and have a good evening.
Thank you.
Take care. Thank you. Bye-bye now. Bye-bye, everybody.